Nonetheless, there are some who will not be eligible, and what should we do for those will be answered by Professor Li from the First Affiliated Hospital of Sun Yat-sen University, so please give her your best attention.
Thank you for your introduction, President. Also, I want to thank the organizer of BTG for inviting me here. Good morning, ladies and gentlemen. Today, I'm honored to discuss with you about the first-line therapy for patients with transplant-ineligible, newly diagnosed multiple myeloma. It's well known that multiple myeloma is a malignancy of elderly. According to the SEER report, myeloma is most often diagnosed among people aged 65 to 75 years old. The median age of myeloma patients at diagnosis is nearly 17 years old. As known on this figure, with the introduction of novel drugs, the 5 years overall survival between 2006 to 2010 was improved compared to that between 2001 to 2005. For patients younger or equal to 65 years old and the patients older than 65 years old, however, the improvement in patients older than 65 years old was far less remarkably than that in younger patients. With the CISS stage and the FISH results, the patients older than 65 years old had a poor survival than the younger patients. You can see the patients older than 65 years old with ISS stage 3 and the poor FISH had the worst survival. This result indicated that age is highly associated with the survival in multiple myeloma patients. Age older than 65 years old is a poor prognosis factor. Similar performance data has impact on the survival. As shown on this figure, the frail patients had a significantly lower 1-year-over survival rate than the fit patients had. What's more, the multivariate analysis indicated that frailty might more remarkably increase the death risk than ISS stage and the poor FISH do, with the highest hazard ratio of 3.1. Hence, frail data and older than led to ineligible for transplant in some patients with a newly diagnosed myeloma. To achieve the best outcome in these patients, then how should we choose the optimal drugs and the regimens as frontline therapy for these transplant-ineligible patients? Today, we will focus on the initial therapy. Drugs available as the first-line therapy are abundant. They could be classified into alkylate, such as methylene, cyclophosphamide, steroids, such as dexamethasone, prednisone, anthracyclines, such as doxing, liposomal doxing, immunes such as thalidomide, lenalidomide, and pomalidomide, and proteasome inhibitors, such as bortezomib and carfilzomib. In the age of novel agents, the corresponding common regimens for transplant-ineligible patients includes those containing immunes such as CTD, MPD, RD, those containing PIs such as VD, MPV, PAD, and those containing both immunes and PIs such as VRD and VTD. In the following several slides, we will briefly review these regimens. For CTD regimen, 3 clinical studies had shown that its overall response rate was greater than 16%, with PFS of 13 to to 25.9 months and the OS of about 3 years. For MPT regimen, the overall response rate ranged from 15.8% to 17.6%. The CR rate reached as high as 23%. What's more, 6 clinical trials showed that the PFS was improved in 5 trials and the OS was improved in 3 trials with MPT regimen. For PAD regimen, 1 clinical trial showed that VGPR plus CR rate after induction therapy was 15.8%, and the 2-year overall survival rate reached 18%. Also, the safety is good for PAD regimen in elderly patients. Common grade 3 and 4 ACE during the induction, including thrombocytopenia, neutropenia, peripheral neuropathy, and pneumonia. In the famous VESTA trial, 6-week cycles of MP plus bortezomib regimen was compared to MP regimen. The primary endpoint was TTP, and the secondary endpoints including the risk rate, TTR, DOR, OS. The result is amazing. By the EBNT criteria, the CR rate of MPV regimen was as high as 13% compared to only 4% of CR rate with the MP regimen. As shown on this table, the time to first response, time to CR, and the duration of response were all superior with VMP to that with MP regimen. As for the long-term outcome, the VMP group had a significantly longer PFS than the MP group. The median PFS was 21.7 and 15.2 months in the VMP and the MP group, respectively. With the median follow-up of 16.1 months, the median OS benefit with VMP was 13.3 months, and the death risk was reduced by 31%. For the adverse events, the most obvious ones for the VMP group were peripheral neuropathy, neuralgia, and diarrhea. Another famous trial is the first trial. In this trial, patients were randomized into the continuous RD18 cycles and the MPT 12 cycles. The randomization was stratified by the age, countries, and the ISS stage. The median PFS with continuous RD18 and the MPT were 26, 21, and 21.1 months respectively. The continuous RD group also have significantly higher 4-year PFS rate of 33% than the RD18 group and the MPT group did. With the median follow-up 14.4 months, the 4-year OS rate was 16% with RD continuous, which was similar to that with the RD18 of 15.7%, however, superior to that with MPT of 15.1%. Most of adverse events were comparable between the 3 groups without significant differences. However, the RD continuous and the RD18 groups had a lower incidence of peripheral neuropathy than the MPT group did. In the registry, VRD regimen combining PI and the IMIL was compared to RD regimen. The results showed that both PFS and the OS was superior with the VRD to that with RD regimen. With the median follow-up over 6 years, the median OS has not been reached yet with the VRD regimen, whereas 16.3 months with the RD regimen. The OS was improved by an average of 1 year with VRD. VRD regimen is expensive, and the prominent efficacy is expected for this regimen combining two categories of novel drugs. As shown in the IFN trial and the evolution trial, the VRD regimen can overcome the poor prognosis of high-risk cytogenetics. Above, we have briefly reviewed the several common first-line regimens for the MM patients ineligible for transplant. In summary, just as recommended by EMN, the patients not eligible for transplant could choose CTD, MPD, VMPRD regimens. Comparison of PFS and OS among these different regimens show that regimens containing lenalidomide or bortezomib, such as MPV, MPRR, and RD, had similar outcomes, but regimens containing only lenalidomide, such as CTD, MPD, and TD, had relatively poor outcomes. Similar to patients younger than 65 years old, patients with transplant-ineligible newly diagnosed multiple myeloma should also receive stratified therapy. Then, how to choose the optimal regimens for the majority standard risk patients with novel renal function, for patients with renal insufficiency, for patients with high-risk FISH, and for patients with poor economic status. A meta-analysis had compared the relative efficacy with RD continuous to that with MPV, MPT, and MP regimens for patients with transplant-ineligible newly diagnosed myeloma. This analysis screened 1993 articles, and the last 88 articles were included in the review, representing 52 unique trials. A network analysis was done to compare RD continuous, MP, VMP, and MPT regimens. As shown on this plot, the results show that compared to the other three regimens, RD continuous decreased the relapse risk by 31 to 62%, with the hazard ratio of 0.38 to 0.69. Also, RD continuous regimen decreased the death risk by 25 to 54%, with the hazard ratio of 0.46 to 0.75. According to this meta-analysis, we recommend RD continuous as the therapy of choice for majority patients with standard risk. How about the patients with renal insufficiency? The VISTA trial showed that no matter the CCR was less than 13 milliliter per minute or greater than 15 milliliter per minute or between, the 1 year, 2 year, 3 year OS rate were similar. With the median follow-up of 36.7 months, the OS were of no significant differences in patients with CCR equals to or greater than 60 milliliter per minute, and those with CCR less than 16 milliliter per minute. The data from China also indicated that patients with renal insufficiency could benefit from regimens containing bortezomib. Hence, for patients with renal insufficiency, the regimens containing bortezomib could overcome the adverse prognosis of renal insufficiency. The next issue we will discuss about is the high-risk cytogenetics. Patients with high-risk cytogenetics always have poor prognosis. Across the clinical trials, focus on the patients with transplant-ineligible myeloma patients, we can see that about 10.7 to 18.8% of the elderly patients had a high-risk cytogenetics abnormality. Then was the impact of cytogenetics on the outcome of patients with transplant-ineligible NDMM in the first trial? Could the poor prognosis of high-risk cytogenetics be overcome by continuous RD? In the first trial, among 762 patients with a FISH result, 19% of patients had high-risk cytogenetics, including translocation 414, translocation 1416, and the 17p deletion. The results show that, similar to RD and the MPT, RD continuous could not overcome the poor prognosis of high-risk cytogenetics on the PFS. The 3-year PFS rate was 3%, 10%, and 3% with the RD continuous, RD18, and the MPT regimen, respectively, without significant differences among them. Later, the OS was improved with the RD continuous compared to the RD18 or MPT for patients with high-risk cytogenetics. However, the VISTA trial showed that the median overall survival were 14 months and 41 months, respectively, in patients with high risk and those with standard risk cytogenetics, with no significant difference between these two groups. Therefore, regimen containing bortezomib might be more optimal for patients with higher risk cytogenetics. The last issue that needs to be considered is the cost. As shown on this figure, 18 cycles of RVD RD cost about 517,000 RMB and 417,000 RMB respectively, while 8 cycles of CTD or MPD only cost about 5,000 RMB. Hence, CTD and MPD might be a good choice for patients with poor economic status. In conclusions, regimens containing immunes such as CTD, MPD, RD, regimens containing PIs such as VD, MPV, PAD, VCD, and the regimens containing immunes and the PIs such as VRD, VTD could all be chosen as the first-line therapy for patients with transplant-ineligible, newly diagnosed myeloma. For patients with severe renal impairment, we could choose bortezomib, thalidomide, pomalidomide, cyclophosphamide, or dexamethasone. For patients with high-risk cytogenetics, protein inhibitors improve the outcome in patients with poor prognosis of high-risk genetics. For patients with poor economics, consider CTD and PD. This is the end of my presentation. Thank you for your attention.